Hi Tash, thanks for doing this.
No problem.
This is for the Quality Improvement module for Health Education in West Midlands, and we're just going to talk a bit about the QI project that you did with me
Yes.
when you were in arthroplasty. So if you could just talk us through what the project was.
So the project was looking at the documentation of post-operative instructions in the arthroplasty department. It started off as initially an audit that I approached to during my arthroplasty placement that I needed to do. I wanted something that would be short, fairly quick, but that would have an impact on our practice. And that's something that could be re-audited that would allow me to fulfill the criteria of my CCT in doing a full cycle. So to look at something that had an impact on our day-to-day practice, during my on-call period, whilst working in the arthroplasty department, I noticed that there was quite a lot of variation in the instructions that were written for these patients. And having been new to the department and 11 consultants in the department, each person does something slightly different. It's quite hard to keep on top or remember things when things are just documented as routine for Mr. XYZ. So I spoke to a few of my colleagues. We all felt that this was something that we all struggled with during our on-call weekends, especially. So therefore, we started it as an audit project to see if we could improve it. Because it was audit, we required some guidelines. So we based it on some British Orthopedic Association and GMC guidelines for documentation, particularly pertaining to arthroplasty. We followed this on with doing a SNAP audit. There was no prior notification given to anyone in the department aside from myself and the consultant lead, that was yourself, that we were going to collect this data. And so we looked at the patients that were in the 2 arthroplasty wards and looked at the post-operative instructions that were documented and to see whether or not they fulfilled the basic criteria that would be needed for managing that patient in the immediate post-operative period over the course of a few hours to a few days, while more concrete documentation such as printed or digital notes were being formulated. So while we were doing this, we noticed that from the result that there was actually quite a lot of patients that didn't have anything documented in that section, which may not seem a big deal if you think that there's paperless documentation, but it is a big deal if you are waiting for the paperless documentation to be formulated. Because the patient is going from theatre to recovery. There's a recovery staff that are constantly flitting in and out of theatre trying to ask, when do the clips come out? When do you want the bloods? When do you want the woolen crepe to come down? And then thereafter, the patient goes to the ward, the same problems carry on. And then after that, the patient goes on a weekend or on Friday, Saturday, Sunday, getting ready for discharge. The same problem keeps happening over and over and over again. And the dictations that are being dictated don't get typed up for, at the fastest, it's maybe 2 days. Mostly on average, I found it was about 5 days. So by that time, some patients will have gone home. So it's quite a lot of guesswork or asking people, WhatsApping other colleagues to ask what this was. So we found about just under 80% of patients didn't have anything documented, which was quite surprising. So the results of these were emailed out to everyone in the department, all the registrars and the consultants, and they were presented at the departmental meeting. And it was an open table discussion that we had amongst all the registrars and consultants available to ask that these were the results that we had 78% only of patients that had things completed, and that there were instructions such as how long they want a VT, which for hip replacements, yes, is pretty much standard, but for knee replacements, there's a lot of variation. Or for example, weight bearing instructions for uncemented hips. Some people want full weight bear, some people want partially weight bear. Such as this was discussed, and people have feedback. Most people felt that yes, there should be more consistency in this. So there were obviously registrars and consultants that were not at the meeting. So therefore, a second email was sent out to inform them of the results and the fact that we actually did need to improve our departmental practice for, to be honest, safe care of the patient at the end of the day.
So at this point then, you picked up on a lack of quality,
Yeah.
excuse me, in number one, the documentation,
Yes.
and number two, dissemination of what the actual consultants did. So
Yes.
this was affecting the patients,
Yes.
this was affecting the registrars who might be on call,
Yes.
covering the ward, and also the nurses who are on the ward, and the pharmacists, I presume, as well.
And
So
physios.
And physios as well,
Yes.
yeah, for weight bearing status. So you had to come up with an idea. So what was your idea then? How did you make this simple?
So it has to be something that is easily to remember. So we came up with A, B, C, D, E. Alphabets, first five letters of the first five letters of the alphabet, 6 letters. So we thought that the basic things that we really needed to look after the patient was antibiotics. A for antibiotics. What antibiotics do you want? It changes from revision patients. Each consultant has their own preference. For example, revisions may need longer course of antibiotics, so specification of what antibiotics you require. Secondly, bloods. You want to have bloods done. Some people want 24-hour post-op, some people 48, some people want same day if you've had a lot of blood loss in theatre. Then we looked at closure material, a lot of variation again there. And for example, revisions, you might want to leave the sutures in longer. So when did you want the closure to come out and what did you use? There's a little bit of modification adjustment that had to go on in the second process that I'll come to later. Check x-ray, if you wanted one, any specifications you had on it. Then D was DVT, so thromboprophylaxis. Did you want oral, chemical, mechanical, any changes in the mechanical? Patients may have skin conditions that you want to avoid or peripheral vascular disease. E was exercise, weight-bearing status, partial weight bearing, any restrictions, if so, how long you wanted the restrictions for. And then F was follow-up. That was when did you want to follow this patient up, 6 weeks, 3 months. And then there was an additional section we left for people that could add additional information.
Okay, so looking back, if you look back at some of the actual operative pathways, the major pathways we use for arthroplasty, this was all being put in a very small section at the bottom, wasn't it?
It was only 6 lines.
6 lines, it was difficult to fit all that in. And there was also some repetition from things that the nurses had filled above it.
Yes.
So the plan, as I remember, was to change that to have one sheet just done by the surgeon and the nurses do their checks elsewhere. So there's no repetition, so it's almost along the lines of lean, yeah?
Yes.
So we're putting the minimum amount of work to get the maximum amount of information. Hopefully standardise across the board to make life easier for the patients and all the ancillary staff, nurses, physios, pharmacists and the registrars as well. Okay, that's fine. So you came up with that.
Yes.
Is there any way that you can sort of link that together with PDSA?
So in terms of the
planning?
So we had to formulate something that was easy to use, circles with a little section for free text. It wasn't essential. We made it clear that it wasn't essential to complete it. It was more Ed More. That was the main goal, to just us to remember this is what needs to be put in. So we formulated a little tick box kind of circling for a page. We trialed that. We first showed it to everyone else in the department that this would be what you would be encountering over the next XYZ weeks. Then there was a lot of communication with the Vast Church team, which is our preoperative and our admission ward team, that this would need to be incorporated into a certain page. There was communication with the senior nurses in pre-op to see if that could be streamlined further, to have it incorporated in earlier. And then in the final, there was myself that had to make sure that things were being incorporated on the mornings of the surgery, that this checklist was available should people wish to use it.
So in the planning part you just described very nicely there, you effectively recruited a team, didn't you?
Yes.
So that was Vast Church initially,
Yes.
and then you took, which is the admissions unit,
Yes.
and you took it a step further forward
Yes.
from that
To try
include it
bringing
in
it forward.
pre-op.
Yes.
Okay. So there were clinical staff, which is yourself,
Yes.
the surgeons doing the op notes, and there were non-clinical staff, some of the clerks on Vast
Yes,
Church.
yes, the receptionist that helped out.
And then there's also clear information for the physios, okay? So then the next thing is when you're getting these QI projects started, was to find a mentor experienced in quality improvement.
Yeah.
So I presume that was me then.
Yes, it was yourself. Yes.
Okay. And so then we carried out the audit and then we changed practice. So really, if you look at how you develop an aim for a project using the SMART criteria, which are specific, measurable, attainable, relevant and timely, this fits very nicely into that, doesn't it?
It does, yes.
And as you said, it was just a tick box thing, wasn't it? So you
It
didn't
was
have to write
circling,
too much.
tick box. We wanted to make it as efficient as possible, as simple and clear.
So that was the planning part. Then the doing part, it's a process that is very changeable on the ground,
Yes.
isn't it? So what sort of problems or difficulties did you experience in the actual doing part of this?
So initially, I think, firstly, incorporating the forms, that was a little bit. There was a few hit and misses in terms of how often the forms were available. Secondly, it was it's something new, I think, is you've introduced something new into the system, it's a change, is trying to get people to use the form or use it for this purpose of being an aide memoir. I think that was a lot, and a lot occasional reminders needed to be sent out to the department and the team, the clinicians, that this was being available. And also, I should have pointed out that we did need to inform the recovery staff that yes, you will be encountering something new. Don't look on page 36 on the bottom, also look out for this form. This may make your life easier. And then the ward staff and the physios and pharmacists, everyone needed to be also informed that this form was coming out. Getting people to fill out the form was a little bit of a problem, but that's expected. Not everyone wants to use the form, which is completely fine. But then we went on to re-audit if this form or this EdMMR had made a difference, and followed up with not just the clinicians, but everyone else, the multidisciplinary team, the physios, the nurses, the recovery staff. Did they feel it made a difference? The other non-orthoplasty registrars or doctors looking after patient. The real purpose was to improve patient care. And has that been achieved? I think that was the real goal here.
So what feedback then, once the studying
Yes.
part of the PDSA, what feedback did you get from, say, the ward nurses or the people at the weekends who were trying to organise discharge?
So we gave out anonymous forms to allow people to fill out what they liked, 3 good things, 3 bad things, and anything extra. It was just given anonymously. People returned it into a little box and left it on the ward. Overall, the overwhelmingly feedback was very good. I think it was really nice to see that most people really appreciated the fact that there was something so clear and that avoided repeatedly asking, things being lost in translation, and it was just clear cut, easy to find. Overwhelming, very good. As I did say that we left areas for improvement, people could offer what they think was, and that was really good because we found that there was a little bit of repetition. For example, closure material. It wasn't always necessary to specify what it was because the nurses were filling it out already. Also things such as wool and crepe or adjustments in terms of maybe medications, duration. So it was really good to get that feedback because I think the physios and the nurses, especially the recovery staff, actually did give things that perhaps we wouldn't look at directly as clinicians, but that was valuable for their handover. So getting that feedback and making adjustments to the second version of the form was quite useful.
Okay, so that brings us on to the acting part of the PDSA plan. So we ran it,
Yes.
we rerun it,
Yes.
we then got feedback from all the stakeholders that would be
Yes.
using the form, and they seemed to like it.
Yes.
We made a couple of changes, did we?
We did. We made it a few changes. So firstly, we needed to make sure that the format fitted in with the pathway because people said that, consultants said that they would be willing to fill out the form if it was there in the pathway. So we made sure that the format fitted, firstly. Things such as certain closure materials were eliminated, more streamlined. Overall, it was made that there was areas for signature, people to document exactly what was already there in the free text part, but just better and was simpler to do. So that was adjusted in terms of format, and then a lot of communication in terms of verbal and email were sent back and forth with the preoperative nurses that play a role in making changes to the integrated pathway in the end.
Okay, that's very good. So the ultimate plan, which hasn't quite happened yet, as I understand it, is to have that page in the pathway changed to
A full page,
the
yes.
A, B, C, D, E,
Yes.
F.
Yes.
Okay, and we're going to get that done, I understand, when we reprint the
Major.
arthroplasty books, the
Yes.
major arthroplasty
Yes.
books again.
Yes.
Okay,
I
that's
think
fine.
that's still under review.
Okay, all right then. So what did you get from this? What did you get from doing this project?
I think, firstly, I think the practice in terms of documentation and handover has been overall achieved. I think the second audit proved that there was a 20% improvement in people actually documenting in the pathway. That, firstly, has been achieved. Secondly, it's taught me a lot in terms of, as a trainee, of not just achieving the full audit cycle, but in terms of putting in an implementation myself and the hard work that goes into implementing something and actually making a true change in clinical practice is hard work, but it's quite rewarding, and it's a process to learn in terms of working with a multidisciplinary, both clinicians and non-clinician team. So that is something alone. It's overall improved my own documentation and notes.
Yeah.
Every time I do it, I think A, B, C, D, E, F.
Yeah, mine
Have
too.
I put it in too myself? And A, B, C, D, the first letters of the alphabet are quite easy to remember, I think. So thinking of something that's easy to remember, easy to document, I think that's the overall learning I've taken away.
Okay, so they're the good things. what were the main stumbling blocks? I mean, it's obvious that orthopaedic surgeons don't like change and don't like being told what to do, and certainly don't like flow charts or pathways. What do you think was the most difficult things, or the most difficult thing in doing this?
In terms of, I think the hardest part was getting the pathway introduced.
Okay.
That was really hard work to ensure consistency, I think, because if from the non-operating side, if you don't ensure that the consistency of the pathway is there, you need to give time for people to get used to seeing the pathway before you can actually re-audit to assess for change in practice. Otherwise, it's not a fair re-audit, to be honest. And I think getting that pathway after the first audit cycle reintroduced was the hardest part, because it involved a lot of coming in earlies and logistics of trying to incorporate with the pre-op team and the Baschurch team and the ward staff. I think that logistical management was the hardest part, but it's a learning process both for myself and for everyone.
Yeah, I agree. I think from the consultant's point of view, some consultants will just let the registrars do all that kind of stuff, and I think they're the ones that we saw the best results from, where the registrars were doing it.
Yeah.
But also now as a consultant myself, I do this. I think the A, B, C, D, E, F. So I think it was a good project. It's certainly improved documentation, and it's a really good example of a really simple thing to do. But I think you've very nicely highlighted all the problems and the sort of the process. So moving forward, if you were to do another study like this, how would you do it differently?
I think I would probably, because I've learned the process that you need to, the amount of non-clinical staff that you need to incorporate, and I think I hadn't really realized how much up the ladder in terms of the management staff I would need to get on my side and to liaise with early. And I think involving them earlier on would have made my life a lot easier, and I think I would definitely do that next time.
Yeah, it'd be a lot less work for you. So that harks back to recruiting your team.
Yes.
So I think it's really important. I think that for me, it's the same. That was the biggest learning point from this project, was actually if you recruit the right team and get all the right stakeholders, because at the start, then things are easier for everybody, rather than relying on one person, which was you.
Yes,
having to also have the early starts and what have you. I remember you going around and sticking the sheet in the pathway. But yeah, if we were to do something like this again, then I think identifying everybody that you need to have in your team as stakeholders. And I think that's a benefit, but it also has some pitfalls insofar as you can have people who have very little input into this wanting to have more input and wanting to have their say.
Yes.
So it's having your say, not having your way, effectively.
Yes, I think that's variable, but I think recruiting.
But I think in general it worked really nicely. It's a really good example of a quality improvement project. So just to summarise, we did a SNAP audit first. Then we introduced it.
Yes.
Okay, and then we re-audited it, and it was better.
Much better, yes.
And we got feedback from the staff and all the people, including especially the non-clinical people and the people on the ward, who actually get on top of what's to be done for patients so they can be discharged in a timely fashion.
Exactly, yeah.
So thank you very much for doing this, and thank you for all your hard work.
Oh, pleasure.